question.
Sickle cell. I hope you do have the PowerPoint available to you on sickle cell. I mean, that's pretty self-explanatory. I hope to get the voice thread done, but we will see. I mean, you've got the reading in the chapter, you've got the PowerPoint, and I will do my best to get that. I thought I had one, and I've been looking for it and can't find it, so I need to redo it. So that's on me.
In terms of the Wonder essay, our goal is to have that all back before your last test. So that's what we're doing, right? We're getting all those grading done, plus all the other stuff. I just wanted to make it like for me, I'm actually going to go visit my son at West Point on the 10th, so you won't see me here. We will have Dr. Erica Timko Olson here in the Twin Cities administering the test, okay, and Dr. Beacham in Rochester. Okay, so that's how it's going to work for you guys. We will be there though for your ATI the day before, okay? In the Twin Cities, and then in Rochester, Kelly will be helping with the ATI.
We've got head nods.
Got it? Okay. Any other questions about that stuff? Okay. Great.
All right, then. We can, so today we're going to have 2 lectures, and I'm hoping to get through a lot of the material fairly quickly. Kind of dense topics, but we want to really concentrate on the pediatric implications because I think you've had neuro and you've had some musculoskeletal. So we're going to look at what we really concentrate on in the pediatric populations. And then I believe if we have time, we've got some Kahoots as a review for the topics that we're going to go through. So that's kind of an impetus to hopefully get through some of this rather quickly. Any questions before I start? All right. So the CNS system, as you know, it's the spinal cord, the brain, and that occurs during fetal development, right? That all is formed and develops during fetal development. And like every other system we've talked about, things can go awry. So we look at in fetal ultrasounds, and Dr. Summerness might be able to talk to this a little bit in more detail if you've got questions, but in a fetal ultrasound, we can see how that spinal cord and vertebrae are forming, and oftentimes if there is a malformation, something that we'll talk about a little bit more, but like spina bifida, where there's a non-closure of the spinal column or the vertebrae, they can actually go in and do surgery pre-birth to close that malformation. So we look at the myelination of the nerves, and that's what's so important about our spinal cord, is that all those nerve endings, right, come in and really dictate our movements and our abilities to perform different functions. We also know for the central nervous system that the skull is a great protector of our brain. And for our infants, the sutures and the skull, the fontanelles don't fully close until between about 12 to 18 months. So we're always concerned about the size of the skull, how the brain is growing, and how the skull is forming and fusing. And we know that the brain and spinal cord are covered by the meninges. One of the main concerns when we talk about any kind of spinal cord injury is the potential for increased cranial pressure. And because our skulls after 12 to 18 months are fused, if we have a brain injury and that there's swelling, there's no place for that swelling to go because it's in an enclosed skull. So the only place it can kind of press against the brain matter itself, or if it's severe enough, it causes herniation and it pushes the brain down through the opening of the skull and down into the spinal cord. So we're very aware of, and we monitor individuals that are at risk for intracranial pressure for signs and symptoms that their intracranial pressures might be rising. And some of the things that we look at is movements and levels of consciousness. Initial signs can be really subtle. So that's where your assessment skills and those, getting a good baseline when you come in to when you come on shift, when you assess your patient first, getting that baseline so that you know the patient, how they're exhibiting their behaviors, what their pupils look like and things like that, so that you can actually assess and catch some of those subtle changes that may be occurring. And that's something that kind of with more practice and experience, you'll pick up on more. But it's also when you know that baseline, or you know what the normal or typical should be, and something in your gut just says something doesn't look right, that's the time to say, can somebody else come in and take a look at this patient, or this is what I've observed, what do you think? And we know, as in everything when we're talking about pediatrics, signs and symptoms certainly, or especially the signs, are related to age. So the way a person may exhibit an increase in ICP changes as opposed to whether they're an infant or whether they're able to communicate and things like that. So in our infant population, nonverbal, but a high-pitched, irritable cry is one of those things that you really don't forget and is pretty characteristic. We've all heard kids cry. We've heard kids cry when they're just kind of cranky, and then we've heard perhaps children cry when they're really, really hungry or really frustrated, but this is a higher pitched and they don't soothe well. So it's kind of like if the child typically, does get upset, but that means that they need to be fed, or they need a diaper changed, or they need to be burped or something, when you do those soothing, or maybe they just need to be held, when you do those soothing interventions, if you will, the child can settle down. These kids don't. They're really difficult to soothe. If you're assessing the fontanelles, they could be tense or bulging, because where are we going to see, right? Just like that ICP is elevated, and if you've got a fontanelle that's still open, you will see that fontanelle bulging. And that would be continually, whether they're crying or not. So all kids, if you've got an infant who is crying and you watch the fontanelle, or you keep your hand on the fontanelle, you'll feel that fontanelle move as they cry, because crying increases ICP. So another thing we would like to do is keep these individuals as calm as possible. So crying is not a good thing when a baby is at risk, or a baby has increased intracranial pressures. We will see that irritability, poor feeding, so they're not really organized in what they are doing. If the ICP is high enough, and I have never seen this in an infant, but the sutures could also separate, which in some ways is a good thing, because then we're not confining that pressure on the brain. But that's a significant rise in ICPs. And the eyes, a sun setting sign, that's kind of when you just see kind of the eyes kind of going down as if the eyes were the sun setting under the horizon. And scalp veins would be distended, and again, another sign of increased pressures.
What is the sun setting sign caused from? Like, why is the pressure for size down?
That's actually on the optic nerve, and the nerves that control the eye are being impacted. So it's more muscular as opposed to the optic nerve, but yeah, it's kind of that pressure. Our children who are more verbal may complain of a headache. We may see vomiting, seizure activity. They may just be drowsy and lethargic and difficult to rise. They're not going to be acting like kids. right? So they're not going to be wanting to go to the playroom. They're not going to be wanting a lot of interaction. If they've been a kid that loves screen time, they probably don't want that. That's going to be too much stimulation. And they may, as things progress, have an inability to follow commands. So whereas, you know, they would understand typically what you were saying and being able to follow a command, they're not able to do that. Late signs. So if you don't pick up on those subtle changes and you don't pick up on the bulging fontanelles or things like that, bradycardia is a late sign and not a good sign. Decreased motor responses, decreased sensory responses. So even to a touch or you know, trying to, with infants, we like to kind of tap their feet or move their feet, and usually that will awaken them. So if they don't respond to that kind of a stimuli, alterations in pupils. So we check pupils and alterations in pupil size and reactivity. Posturing, really late sign. Decorticate, decerebrate, you're familiar with those terms? Okay, so, and there's a table in your book that goes through kind of the stages of, but late signs, and I think there's 8 of them, so 7 and 8 would be decorticate, which is when they flex. So a posturing motion, but it would be when kind of the arms come up and they're flexing really, really tight, and it's not a controlled flexion, it's in response to the ICP. And then a later sign would be decerebrate, which is extension. And again, it's a stiffening of all of the extremities. And with these, you would see a decreased level of consciousness and coma. And certainly any injury to the brain, any increased ICP, if it gets to the point where it's herniating, which when it does herniate, we tend to see bradycardia, irregular respirations, Cheyne-Stokes breathing. You're familiar with that term? That would be one, and there's a third that I'm not going to think of right now. But there's three different kind of signs of really, really late impending death, signals of herniation. And I'll probably think of the other as we go on. But it is in your book, so you can just fill in the blank also, if I don't. Describing the level of consciousness of your patient is always important. And so, you know, are they fully conscious, awake, alert, and oriented, all that kind of good stuff. Are they confused? So is there impaired decision making? And we know that for an infant, we really can't comment on that. But for an older child, we certainly could. Are they disoriented? Are they lethargic? Has their speech become sluggish? Obtunded would be one that arouses only to that stimulation. So, you know, shaking, touching on your shoulder or shaking the feet. A stupor is that they only respond to vigorous and repeated stimulation. When an individual's in a coma, they really don't have any appropriate response to verbal or noxious stimuli and then a persistent vegetative state is permanent loss of function. So that's when we talk about level of consciousness, those are the kind of differentiations we can make in describing our patients and what we are assessing. Glasgow Coma Scale, yes. There is a pediatric version, and it looks at eye-opening, verbal response, and motor response, just as our adult one does. And there you see kind of how we can rate them, and a 15 is unaltered. So you're awake, alert, and oriented, you're moving everything, your verbal responses are appropriate, that would be a 15. Anytime we're suspecting neurologic involvement with a patient. We want to make sure we do a thorough neuro exam, taking vital signs, doing a skin assessment, pupil checks, how reactive or what do the pupils look like. When you have a patient who has had typical pupillary responses and then the next time you come in, you see one that is very, about a 4 or a 5 and does not react to light, not a good sign and really kind of sucks. But doing those pupillary checks are really important. Checking motor function. So are they able to follow commands? Are they able to grasp, to push against? So just some basic kind of motor skills. Are they still able to swallow? When we're concerned about ICP and we're worried about motor function, we're also worried about, can this individual still eat? Can they still take in liquids? Can they still swallow these pills? Or do we have to figure out a different way that they're going to be able to get the medications that they're prescribed? And we would want to check reflexes. And this is a picture from your book, and it just shows some of that, the differences in pupillary sizes and things that you might see. Here you see some drooping eyelids, which would show some muscular deterioration or some nerve deterioration on the one side that would then droop the eyelid. D is pretty much what I was talking about in kind of those full-blown pupils and not reactive to light. Certainly, if it was a dark room, you might see really, really wide pupils. But the minute you shine that light in or turn a light on, you would expect those pupils to constrict. When we have pediatric patients or any patient really with suspected increased ICP or we're worried about their ICP, we want to to monitor it. And I don't know, has anybody had a patient that has or been in an ICU where there's a patient having their ICPs monitored and want to talk about it? Because those are two different questions, I know. Anybody in Twin Cities? I do have somebody here in Rochester, yes.
I've been in like one-to-ones with patients who have had external ventricular drains put in, and they have a sensor there, and it's monitored on the screen. So,
right. So we can put in a ventriculostomy, which accesses and it actually goes into the ventricle, and you can read the pressures to see what your patient's doing. Needs to be really, 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 really well labeled, because the tubing does not look very dissimilar from IV tubing. And the hub where that inducer connects to read those pressures. So the thing you don't want to do ever is kind of open it to air and have it draining to the outside. Number one, you're introducing potential bacteria. Number two, that sudden shift can really damage the brain and what's going on with the pressures. Nor do you want to mistake it for a jugular or a subclavian line and put in medication. So those kinds of things, and that's why, the ICU is, really intense, and hopefully you saw those lines labeled very clearly. ICP, do not, whatever protocols the hospital, because there have been incidents where people have mistaken an ICP of, ventriculostomy for an IV line and really caused some fatal consequences to patients. And you never want to be in that situation. EEG to monitor brain waves and things like that. On kids, that can be really, really tough because they don't understand that, you're going to have these electrodes pasted to your head and you're not supposed to take them off and things. So that can be challenging. Lumbar punctures, there's a neat picture in your book of a small child, and the nurse just kind of envelops them to get that nice C-curved back. But when you think about it, asking a child to do, if you've ever had any kind of a lumbar puncture or a line started for pain management, a spinal, or it's nerve-wracking. It's a very vulnerable position, and then if you happen to glimpse the size of the needle, it can be really terrifying. And so for these children, to get them to lie still, a lot of times those are done under some sedation, some light sedation, just so they're a little more chill, but it really can be difficult to get that curved back. And you think about the space between their vertebrae is even tinier than ours. So that can be a skill that our practitioners really need to hone and be able to do well. Assessment of, so the time it takes to, so are they reacting to stimuli appropriately? Are they taking longer than typical to answer your questions? When you ask them to do something, is there a delay? Or when you touch them, do they delay in saying, I feel that, those kinds of things. And then CT scans, MRIs, and X-rays, depending on, whether we're looking at hard or soft tissue, bone, or things like that. But for fractures, for swelling, for what's going on in the ventricles, what does the brain look like? And those images can tell us a lot about what's going on. So what we do is assess the level of consciousness, pupillary reaction. We've talked about vital signs. Frequency of assessment would be depending on the status of the patient and the orders of the unit and the protocols that you're under. It could be as frequently as every 15 minutes. If this patient is really severe, they could be a one-on-one. So you could be pretty much at the bedside all the time. And it may be as infrequently as 2 hours. Thinking about, well, no, we won't do that yet. Medications that can be used, corticosteroids you may see used, but that's not the typical anymore. They've gotten away from using corticosteroids, but certainly if there's an infectious process going on, antibiotics, sedatives, anti-epileptics, so we don't want them seizing because any of that kind of activity increases ICPs even more. Sedations, and I would say sedations and amnesics, because we don't want kids, we actually don't want anybody remembering these situations. So if we can give a little something that has an amnesic property, that can be really beneficial to long-term outcome. Just from they don't have the memory of everything they went through and being that hooked up to all those lines and things like that. Barbiturates are our last resort, and then paralytic agents, because we don't want a lot of movement, right? Because we know movement increases intracranial pressure. We would want let's see if we've got we want to regulate their temperature, because we know that temperature regulation comes from the brain. So if there's stuff going on and there's swelling in the brain, they may have problems maintaining their temperature, or they may be febrile. So we want to maintain thermodynamic stability. We want to make sure that they are dry and clean, so that if they don't have a Foley in, we can get one in, or we can just be diapered and change frequently, but just keeping good hygiene. Hygienic care also for the rest of the body. So if they're sweating a lot, we don't want them lying on wet linens. Positioning and exercise, don't want a lot of exercise at this point with increased ICPs. And positioning, we do want to change their positioning. This is a patient you would want to cluster care. You would want to, hopefully, if we're monitoring ICPs, you would want to do your care around a time when the ICP is low. cluster it all, get it done, and then leave them be, because any kind of stimulation can increase the ICPs, and we're looking for that brain to recover, to not be challenged more. And then families need a lot of support in this situation. It's a really scary time. There's not a lot of good prognosis. It'll be a lot of, well, we just need to wait and see how this goes and things like that. That's very frustrating for families, and when you've got a child in that situation, very scary, very concerned. So as much family support as we can provide and as we can bring in for them. So, you know, this would be a time where, you know, do you want to talk to a member of the clergy? Is there someone we can call? You know, what can we do to answer your questions? Those kinds of things are really important for families at this time. Any questions on that? So when we look at the infections, we think of meningitis. When we talk about intracranial infections, I think that's kind of the all-encompassing situation that we think of. And the CNS in itself doesn't have a lot of room to respond to infection. It's a fairly closed system, and we don't see a lot of ability, kind of like our bloodstream, or if we get a cut, our system can take care of that. Not quite the same in the CNS. It's difficult to determine whether something's bacterial or viral from the clinical manifestations. So when you start seeing infection or something that is showing different behaviors, the person's exhibiting different behaviors, it's not like we can say, well, if they do this, it's bacterial or it's from this pathogen, and if they behave this way, it's from this other. There's really no way to tell. So we need lab studies. We need that LP to look at the cerebrospinal fluid and see what it looks like. What are the properties like, and does it harbor a bacteria? So doing a culture, what grows out. And when we think about an infection, we need to think about the fact that it would be involving the spinal cord and all those meninges. And so those meninges get irritated, and that's what we see is a lot of the brain involvement because of that irritation. So bacterial meningitis, I just want to make sure I keep on, okay. Bacterial meningitis is an inflammation of the meninges and the cerebrospinal fluid. We have seen a decrease in it since the introduction of the Hib vaccine, but I was just reading recently that there were a couple cases diagnosed in different areas of the U.S. It can be caused by a myriad of pathogens, bacterial agents. And again, there's no way to really determine what it is until a CNS is done. It's highly transmittable, which is why the vaccine's really good, because it's transmitted via nasopharyngeal droplets, and you really are able to transmit it before you actually know you've got it and have those severe signs and symptoms. It appears as an extension from a bacterial infection somewhere else, and it then travels through the CSF, but there's no way to really determine necessarily how it got in or why in some individuals it travels in and in others it hasn't. And seasonal, late winter to early spring, which is where we are right now, seems to be the height of its seasonal variation. So LP is the definitive test. And again, therapeutic management, we want isolation precautions on these individuals because it is highly transmittable. Antimicrobial therapy, we want to restrict hydration, so I's and O's will be really important because if their ICPs are up, extra fluid on board is just going to exacerbate that. So we want to keep their I's and O's, keep a good eye on that, and then if they need mechanical ventilation as supportive care, we would introduce that. always looking for systemic shock signs and symptoms and intervening hopefully before they go there, and controlling of seizures and temperature. Question?
That it appears as an extension of an infection from a different part of the body. So
Yeah.
does that mean, like, if you have bacterial meningitis and do I catch that from you, or do I just catch the bacteria and it goes somewhere else in my body? Or is it specific to meningitis?
That's a good question. Say, I don't know. Either look it up and let us know, or email me and I'll look it up. I would have to think, I'm not going to guess because I can muscle my way through what I think it is, but in the absence of a clear, definitive answer, in the essence of time, we'll move on. That did that. Okay. All right, then moving on. But thank you for the question. Non-bacterial meningitis or aseptic. So that's more of a virus, and causative agents you see there. And again, it's diagnosed on the findings of that spinal and the CFS findings. This onset can be abrupt or gradual, and that its manifestations are headache and fever and a little bit of malaise, so just kind of not feeling. And the treatments are symptomatic, right? Because we know we just need to let that virus run its course. So it's really going to be a symptomatic management and whatever supports the individual needs. Yeah.
So for all of these, both like the viral and the bacterial, do they still get like that stiff neck and have like those reflexes and stuff?
If they're that irritated, yeah. So exactly that, and that's the irritated meninges is what's showing that. Yeah. Any other questions on meningitis? All right then, moving on. Seizure disorders. So seizure disorders are another seizures are another disorder that we can see in our pediatric population. And they can be caused by excessive or disorderly kind of communication between the neurons in the brain. Right? So we know that those are electrical pathways, and if they get interrupted or if they're disorganized, we can see seizure activity. Depending on the site of that disorganization depends on kind of the way it's exhibited and what we see. Seizures are the most common neurological dysfunction in children, and typically they can be a symptom of an underlying disease process. So something else is going on and we see seizures. When an individual has 2 or more unprovoked seizures, they're diagnosed with epilepsy. So if you have a traumatic brain injury or something like that, and or meningitis, and you have seizures, that's not necessarily considered epilepsy. But if you've recovered from that and you continue to have seizures, that would be then a diagnosis of epilepsy. And they can be caused by a variety of reasons. And treatment and prognosis usually require, it's an individualized process, and it's a lot of kind of seeing what's going on, doing the diagnostics and determining the cause, and then treating, and if the underlying cause can be taken care of. Here we see some of the causes of seizures. Head trauma or meningitis can cause acute symptomatic seizure activity, and as opposed to remote symptomatic, which would be brain injury prior, so a stroke or encephalitis or something like that, that causes injury. Cryptogenic, there's no clear cause, and idiopathic seems to have some genetic component, but again, not really defined. And we typically look at seizures and say, are they partial? So do they involve a local part of the brain and a certain localized response versus generalized, which is what we think of as our tonic-clonic seizures.
Because of the different types of seizures, are we going to need to know all those for the...
No. Corey wanted to know if you needed to know all the different types of seizures for the test, and I said no. So that's pretty much just kind of knowing that they can be just a particular kind. So there's focal seizures, which you just see the eyes kind of go off and not be engaged, and then the person will come back. When you see that in a child, it's really hard to know, because kids go off and look off into the distance, or sometimes go into their own world, and so differentiating that sometimes is difficult to a layperson or even to a practitioner, but you may suspect that this might be a focal seizure if the child really doesn't respond for a period of time to any vocal or stimulus. So the goal for seizure mismanagement, the goal for seizure management is to minimize the number of seizures, or control the frequency, or reduce them entirely. We would also like to find the underlying cause and correct that when possible. And so we have drug therapy to manage seizures and reduce the number. Some folks try a ketogenic diet, which is successful in some individuals. Vagus nerve stimulation, so you can have a vagus nerve stimulator, and that seems to decrease the number of seizure frequency in some individuals. And surgical therapy. So if we can identify the part of the brain that is causing the seizure, they can remove that and frequently lessen or eliminate the seizure activity. Status epilepticus is a condition, and it's an emergency condition where there's a inability to stop seizing. So a seizure that lasts more than 5 minutes, or a seizure that doesn't have the person recover and between seizures. So I have a seizure, and the seizure activity stops, but I don't really regain full consciousness, and I have another seizure. So those are the two things, either one seizure that lasts more than 5 minutes, or multiple seizures without recovery in between, is status epilepticus. Prognosis is difficult to determine because so much is kind of dependent on therapeutic management. Might surgery work? So it's more a, can we remove the underlying cause, or is this one of those idiopathic or things that we really can't determine, where there seems to be that genetic component that we really don't know how to intervene without medications and things like that. So the prognosis really is dependent on a lot of different situations. The individual could need long-term care if they've had multiple seizure activities that has caused brain damage, because the thing to realize is when the brain is seizing, it's not getting the oxygen it needs. So just like when we have a myocardial infarction, and you're in this disorganized heart rhythm, and the heart's not beating the way it should. Well, when you have a cerebral infarction, that's happening in the brain, and so there could be brain damage if those seizures aren't controlled and they go on for too long. Some people, you may be familiar, have triggering factors. So some have olfactory triggers. They smell something, and that other individuals, you've probably seen either on rides at the amusement park, or maybe some movies or entertainment kind of things where bright strobe lights, if you have a seizure disorder, you might not want to do this. Sometimes those kinds of stimulation can trigger a seizure in individuals. And the goal, as for anyone, is to get them to to control where they can manage their seizure disorder just like a diabetic manages their diabetes or an asthmatic manages their asthma, and live as normal life as possible.
Dr. Beacham, we have a question here.
Yes.
Yeah, I don't have a question. I just have a comment. I work in EEG. I study epilepsy for my job, and so I'm pretty sure status epilepticus is called when a seizure is lasting more than 10 minutes, and then that's when we would call it. But then with status 2, the patient is more lethargic. They're not really there. They kind of put it with like a encephalopathy type of brain disorder. And then like with triggering factors, you can also try hyperventilation. A lot of people can trigger their seizures with induced exercise.
Okay.
So just some extra facts.
Mm-hmm. Thank you. Your book has 5 minutes for status epilepticus. And if somebody sends me an email, I will remember to look up and post a more definitive if it's going to change. If it doesn't change for purposes of testing, at least 5 minutes is what we'll go with for now. Fair enough? But thank you for bringing that up. And who was that? Just by Chloe? Oh, people here know. Chloe, what are you doing in the Twin Cities? They're missing you here. Thank you, Chloe.
We have it. She's getting to go to an event tonight, so she.
I'm totally teasing.
Yeah.
I was just like.
She was approved. She was approved by Chris and I, just so everybody knows. It was
No, but I'm like, we've done a much better job at making this all one class if 3 people here knew that was Chloe by listening to a voice.
That's funny. Just so everybody knows, we don't allow too many people to switch sites for classes, because you can imagine how that would be. It has to be approved basis on that. So Chloe does attend to the classes in Rochester. She's here today. So say hi, Chloe. We have a guest today.
Yes, I see another question in Twin Cities.
Yeah, we were just looking at ATI and it says it lasts longer than 30 minutes. So some mixed information, I guess.
That's Jane.
So Jane, can you send me a page number on that for ATI, and then I will definitely get some
Yeah, it's like what she said, the seizures when they
inclusion on that.
It's going to keep occurring within the 30 minutes.
So there's a clarification with that.
Yeah.
Yeah. So not just 30 minutes, but when they keep occurring in that time frame.
And like they don't have
Once it's
enough
triggered.
space in between the seizures, so like say they have one seizure and it's like maybe like 5-second break, and then they have another one, and then that continues for 30 minutes. So it's like 5.
Like, yeah. Exactly. Interestingly, we're talking about repetitive seizures, or maybe a cluster of seizures that start and then aren't being able to be controlled over a period of 30 minutes. So I believe that ATI might have a word in there that might clarify that, but just let's make sure, we'll make sure. Interestingly, last semester I was getting a coffee at Caribou and I heard somebody scream very loudly in that little bench that's over in the corner by the escalators. And another guy was in the line with me too. He was a med student. We rushed over there, and there was a gal having grand mal seizures on the ground. And I don't know a ton about, seizure. I mean, I know as a nurse, but I hadn't done it in so long. But I mean, we just kicked into gear. I mean, we knew exactly. She had dental work, had a history of seizure activity. Interestingly, the physician who did the dental work was walking by and knew this patient. So we had this thing. So we had about a 30-minute. We did get, he called 911 and got some help for her. But very, very interesting to watch that. And it was over and over again. She'd relax, kind of come to a little bit, and then would start right back up again. So she had to definitely get some help. So had, I think, 3 extractions and a couple other things done to her. So triggered that.
Thank you. Okay, so, oh man, I don't like this today. I don't like it. Febrile seizures can be common in our infant population, infant, toddler, early in childhood. It's a transient disorder. Okay, it's not epilepsy, and quite often it occurs once and then they don't have another seizure for their entire life. But it's not uncommon. You can see 2 to 5% of children may have a febrile seizure. Usually occurs between about 6 months of age and 3 years. Typically after the age of 5, we don't see them. And so it may have something to do with just that immature kind of system still developing. And when that fever hits, it's twice as frequent in males as females. Again, don't really know why. The cause is uncertain. They think it may be associated with a viral infection, that it may be associated with a rapid change in temperature as opposed to the degree of the fever. And again, the parents will come in really concerned, really upset. And it's the kind of thing that if there's just been one and the child now is appearing fine, they will watch. But there would be no real treatment for that if it was a seizure and it stopped and did not repeat. Anybody have a febrile seizure? Know of anybody that has had?
Or had them, like, not frequently, but she had like her eyes open, like every time she'd get sick.
Get sick?
Yeah, she was like a preemie. I don't know if they were
Something else going on.
Yeah, please.
Okay. Hydrocephalus. Hydrocephalus is caused by an imbalance in the production and the absorption of CSF. So we are constantly making cerebral spinal fluid and constantly absorbing it back, reabsorbing it back into our bodies. And so we've got a pretty constant level. If there's something that gets in the way of either the production or the reabsorption, we run into trouble. And when there's too much production and not enough reabsorption, that cerebral spinal fluid builds up and builds up, and it's kind of like when we fill a water balloon, right? If the water's got no place to go, that balloon just gets bigger and bigger. So the space that we need to hold the CSF needs to be bigger, and what tends to happen is the ventricles are increased. So we'll see an increase in ventricle size within the brain. There can also be blockages between the ventricles so that the ventricle doesn't drain. There's an obstruction there. And so there can be a couple different kinds of malformations that would cause hydrocephalus in our infants. And here we see the communication that should be occurring within the brain. We see the lateral ventricle, and then how it's connected to the fourth ventricle, and then to the aqueduct in the third ventricle here, and drains down as well. So if there's a blockage anywhere, if there's a tumor that cuts off a portion, that pathway, there's problems. And here we can see a picture of the brain with enlarged ventricles. Okay. So causes of hydrocephalus, they can be caused by developmental abnormalities. And we see that when there are developmental abnormalities, a lot of times we see that evidence of that in early infancy. And we can see that there's swelling of the brain, or the head is just larger than we would expect it to be. Or when we do the measurements of the head size, we see that the head is growing in a rate faster than the rest of the body and that we would expect. So that's one of the reasons why head circumference is really an important measure. And it's a difficult measure, because where you take your tape measure, and I come back in 2 days and measure it, and there can be a little bit of variation. So, making sure that the markings, how you've done it, where you've actually placed the tape measure, to document that so that it's done at the same place or as close to the same area. You want it right at the back of the occiput, so it's at the kind of largest area in the back of the head. Really important. So neoplasms, infection, and trauma can also cause hydrocephalus. It can be associated with a myelomeningocele, which is one of those incomplete closures or bulges in the spinal column, which would create a bulging somewhere along the spinal cord, and a lot of times that is also associated with a hydrocephalus. Relief of the hydrocephalus. So if there is a tumor, if there's something there that can be removed, removing that. Treatment of complications. So again, when you've got swelling, when you've got increased pressures, there could be seizure activity and things like that. Assessment of problems related to the effect on motor development. So making sure that we're doing assessments of, is this child meeting milestones? Is their gross motor development occurring as we would expect, and really monitoring that. And the treatment most often is surgical, and it's a placement of a ventriculoperitoneal shunt. So if we look at the, so it would be a shunt that goes from the ventricles here down and into the abdomen. And so draining that excess CSF into the abdomen for reabsorption. So there's a picture of what that looks like. And a lot of times if a child has, and it's typically called a VP shunt for short, ventriculoperitoneal VP, if they've got a VP shunt, quite often you can actually see the tubing. It's internal, but you may be able to see and palpate the tubing under the skin of the neck. One of the managements of this and risks is shunt infection. And so once a shunt is placed, we expect to see a decrease in those pressures and a decrease in the signs and symptoms we were seeing because of the increased pressure. And that child goes home and they're good, and then all of a sudden they start with, running maybe a little bit of a fever, but also exhibiting some of that irritability or some of those signs and symptoms of increased ICP. It could be that they have an infection of the shunt, and that requires another surgical procedure to remove the shunt and replace it. Sometimes, for whatever reason, a shunt gets blocked and it stops draining. That would be a reason for replacement. Sometimes these shunts stops working, but the child's system has grown and developed to the point where they don't need the shunt anymore. And so it's just kind of there, but so long as it's not giving them problems, nothing's done. But you can see here the kind of infections that might be introduced: a septicemia, a bacterial, endocarditis, so anything that's happening that may impact and infect the shunt would be.
infections common?
You know, they're not uncommon, but I will say it's hard for me to say because when you work in a hospital environment, you get a very warped idea of kind of what's common and not common. So it's not like, oh my gosh, you got a shunt infection. They're more common than that, but I think there are a lot of kids out there that never get a shunt infection. I don't know the percents though. Yes?
I'm confused when I was reading the book. So it drains from the ventricles, but just goes into the peritoneal cavity.
Yeah, where it's absorbed.
So then how does it get back to like the spinal column?
It doesn't. No, the problem is we have too much cerebral spinal fluid, so it's like we want to drain off some of that excess.
Can it like make it so we don't have enough?
Typically it's not. No. Typically when you've got a situation of hydrocephalus, you've either got too much production or a blockage where it's not draining. So they put the drain in to overcome the fact that either something didn't develop as it should. So instead of it being able to drain, it's almost like a dead end pouch. So it's not draining. So they put the drain in to have that drain. And it's at a level that if it doesn't need to drain, it won't. So it's not like we put it at the it's not like we put it at the bottom of the tank and say drain everything. It's like we put it at the top of the tank and say if it gets above this level, drain it. Make sense? I just had a water heater installed, so I'm all about like the water drains here, the things here. So, and I have hot water, so I'm so happy. And treatment is massive dose of antibiotics, and like I said, typically shunt removal and replacement if they feel it's still needed. So when caring for an unconscious child, an appropriate nursing intervention is to change the child's position infrequently to minimize the chance of increased ICP. Avoid using narcotics and sedatives to provide comfort and pain relief. Monitor intake and output carefully to avoid fluid overload and cerebral edema, or give tepid sponge baths to reduce fever because antipyretics are contraindicated. What do we think we would want to do for? Yeah, see. Everybody get that? Although we want to minimize changing the child's position, we don't want to do it infrequently. And infrequently is like, how often is that? So just to think, infrequently might be once a day, right? That wouldn't be too good. Comfort and pain relief and antipyretics are not contraindicated, so. Yes?
A little off topic, but how high of a fever before the 10th bath should come in? Because don't you want to worry about hypothermia as well with that?
I'm sorry, how high a fever?
For a 10th bath?
Like how hot do you want them to get before you would try to cool them down
With that intervention?
I would cool them down with a cooling blanket.
Okay. So that last one, don't even use a 10th bath?
I wouldn't, that's too stimulating for, now I'm going to be touching them all over for a period of time.
Okay.
If I'm worried about high ICPs, I'm probably going to want to get a cooling blanket or, I don't know if they do the same, but we used to do ice on pressure points. So ice on the wrists and things like that, behind the neck, that can cool. So things like that, as opposed to actually bathing would be I would say that's contraindicated, not because it's tepid, but because it's just too stimulating for the individual.
Okay.
Any other questions? Cerebral palsy is a movement disorder, and it's permanent. And the thing to remember about cerebral palsy is that it doesn't get worse and it doesn't get better. It just it is. And so that's one of the things that I think characteristic but differentiates it from a lot of other conditions is that, that damage that was done is done. And so those movement disorders and those postures aren't going to resolve, and that's what we're left to kind of try and manage. And a lot of times it causes activity limitations that are attributed, and okay, so it's not progressive. That's the best way to say that in one word. And a lot of times it occurs during fetal or infant brain development. So it's characterized by abnormal muscle tone, and it could be spastic or it could be flaccid. Incidence is about 3 per 1,000 births, and it's most common permanent disability of childhood. It does seem to have a connection when you think about the fact that it is due to that brain development. There does seem to be a correlation between having CP and having a seizure disorder, having epilepsy. So prenatal brain abnormalities are the typical cause, and it can be for a myriad of reasons, and they're kind of listed there. As I said, there are several different kinds of classifications, spastic, dyskinetic, ataxic, and mixed. And, just depending on the presentation and what's going on is how these are classified. Infants at risk require careful assessment and monitoring during development. During early infancy, it's really hard to spot when you think about it. When you were if you spent any time with a newborn, their motions are not smooth and controlled. I think sometimes newborns do look somewhat spastic in their movements. And so what we expect as that newborn matures and develops is the myelination of the nerve endings is completed, and then they have smoother and more controlled movements, gross motor movements. So in an individual with CP, that does not resolve that way. And so as they grow and develop, you begin to see more of the limitations that they will have due to their motor, the gross motor implications of their CP. Neurologic examination and a history is often the basis for the diagnosis. And it sometimes takes time because it is going to be kind of watching that trend and seeing how it happens. Neuroimaging may also be used, and metabolic and genetic testing to see if there's anything else going on concurrently. So clinical manifestations, as I said, we would see that gross motor development being delayed, maybe an abnormal performance of those motor skills. So a lot of times walking might not be on a full foot. Alterations in muscle tone. So if it's a spastic kind, you may see some contractures start to develop. Abnormal postures, as there's not good control of some of the muscle groups. There may be reflex abnormalities. So there may be either hyperactive reflexes in the case of someone with spastic, and there may be diminished reflexes in someone with a more ataxic. And there may also be some other associated challenges that the individual might have. There's no direct linkage, but there are some, so it's a gross motor problem. It is not cognitive, although some individuals with CP also have cognitive challenges. And because it's gross motor, it can affect speech and the ability to kind of form words and things like that without having an impact on their cognition. So the goals of therapy for an individual with CP is locomotion, so getting them as active and as mobile as possible, giving communication skills and knowing, maximizing their potential for communicating and how that can happen, whether it's a communication board, sign language, speech, and self-help skills. So they may take additional training to do some of the skills on their own, and they may actually need care or someone to help them with certain self-care activities. There's a lot of assistive devices and braces and things that can be used to help the individual attain ambulation and attain a better posture and things like that in the long run can help. We know that when we talk about posture, we can't talk about posture long term without thinking about the respiratory system and the GI system and what an altered posture does to those systems in the ability to take a deep breath. And so if you don't have good posture where you've got that ability to breathe, and if your kind of speech and swallow are compromised, you may be at a higher risk for things like aspiration pneumonia. So really everything kind of goes hand in hand in trying to maximize the potential for the individual by giving them the supports and accommodations needed in order to do so. So some of the therapeutic management we can see, ankle or foot braces. There may be some orthopedic surgeries in order to correct spastic deformities. So if a child is of an age and they've had a contracture for such a long time, that contracture at some point may inhibit their even ability to sit in their wheelchair or something. So sometimes surgeries to ease those deformities can be performed. We have pharmacologic agents that can treat pain and also relax contractures or the spasticity. And the botulinum A injection, and now there are pumps that can be inserted that also deliver that on a kind of a steady rate that really can help individuals with a spastic CP be much more relaxed and have much more mobility and ability to perform. Dental hygiene, I'm a big proponent of dental hygiene. Everybody needs good dental hygiene. And occupational and physical therapy, again, to maximize ambulation, to maximize what fine motor movements and using the accommodations that are available. And there's more and better ones every year. So kind of keeping up with those. Here we see a little guy using his walker and happy about his ability to ambulate. And then there's tricycles. There's all sorts of accommodations that we can have. There are playgrounds that can accommodate wheelchairs so that they can go up and around and down some of these things. So thinking about those kinds of environments in our neighborhoods. Do we have accessible streets? Or, can we get up and down and in and out of the candy store? My university and but where do kids want to go? And are they accessible and accommodating? And I think more and more we're seeing more and more programs and more activities that are. And again, the prognosis depends on the type and the severity. Moderate impairment, about 85% of patients achieve ambulation. Cognitive impairments, they don't go hand in hand. And I think I told you the story about I had a family sign up for a research study I did. And when they came in, I think the diagnosis they came in under was asthma, but this child had a myriad of comorbidities, as well as a walker, like we saw in the little guy there, and you know, a little bit of slurred speech. So although, and it was really interesting, Mom did not list CP as one of his conditions, but to me it was fairly, it seemed to fit the criteria. So I talked to him a little bit while I was talking to Mom, and Mom said, you know, my goal was to interview the child. And Mom was like, well, I can stay if he can. I said, no, let us try. But my gut instinct was, oh, this is a family I'm just going to give the thank you gift to, and I'll have to write off this interview because this child's not going to be able to participate. I got called out on my own unconscious bias because he was brilliant, and when I couldn't understand what he was saying, and I said to him, I'm not quite understanding that, can you say that again? He would say it in a different way and use different words so that perhaps between the two, and there was only one time in a 45-minute interview that I had to look at him and say, you know what, we'll remember this and we'll ask Mom when she comes back what it is you're telling me. And it was the name of his swim program that had nothing to do with swimming or the Y or anything else. And it was like pulling a needle out of a haystack. But everything else, he was perfect, and he could answer the questions and talk to me just like anybody else did. And that was my bad. And that really was a wake-up call to me about an assumption I had made about a population of people that I needed to overcome that assumption and work on that bias. So I share that because we all have these biases and these things that all of a sudden will come up and say, yep, that's not a valid assumption. That was an assumption, and it wasn't based on anything but a preconceived notion that you had. And I'm really glad I gave him the chance to be a part of the interview. Care and management of CP, assisting the family, because again, the family is going to be a primary caregiver, and there may be things that that child is never going to be able to do for themselves. So devising and modifying equipment and figuring out creative ways. I mean, this is where the, you know, it's not going to be black and white, and maybe there's not an assistive. This is where the parents, the families come up with ingenious ways of doing things that if we listen to them, we could probably be millionaires, because the devices they create, the workarounds they create, the things that they do are brilliant. So working with families to devise and modifying equipment and figuring out what they need in order to support this child. The administration of the medications, safety precautions, recreational activities, speech therapy, OT, PT, and support for the family. So, and I think we've kind of covered all of those as we've talked about them. And then I think this is the last group of neurological things we'll talk about is neural tube defects, and kind of fall into the broad category spina bifida. Largest group of congenital anomalies that we know about. The reason why we prescribe folic acid for all of our individuals planning to become pregnant, or when it is determined they are pregnant, we prescribe folic acid in order to reduce the incidence of neural defects. It seems to have an association. Normally, the spinal cord and the cauda are encased in a protective sheath of bone, which is the vertebral column, right? And when that neural tube doesn't close or the spinal vertebrae don't close, there are varying degrees of results, and those vary based on the level of the defect and the severity. It's not really common, 3 in 10,000 births, and occurs more often in white and Hispanic children. But when it can occur, when it does occur, rather, again, the severity can be very varied. Spina bifida occulta is what they refer to as a hidden spina bifida. So you don't see any external opening, but you may see a dimple at the top of the buttocks, or there may be a tuft of hair or something. And that would be a defect that is at that level. And then spina bifida cystica, which is more severe, is when that non-closure actually comes out of the skin and you can see it externally. And so here we just have a couple of the pictures, the normal typical development with the spinal cord in the middle and the vertebrae around it. Occulta, it's not seen externally, but we can see here there's a difference, right? And that's not closed. As opposed to the meningocele, where the meninges are protruding the skin, and the myelomeningocele, where the spinal cord and the meningoceles. And so both of these require surgical repair shortly after birth to repair that. Because when you think about it, if either of these were to break, if the covering on it deteriorates and opens, that's direct access into the spinal column. Not conducive. And there's a couple pictures before, and these babies would be on their stomachs because you don't want them to be laying on their backs because that will open that and create a wound. So that's pre and then post-surgery with the repair. Some of these now can be seen on ultrasound and repaired in utero. I've not seen one done. Have you seen one done, Dr. Summerness?
No, I have not. But I was part of the overall awareness and aha about, making sure that we fortify cereals and different things with folic acid back in, the late, early to late 90s when I was in the military at first. We finally clued in that, oh my gosh, this is really simple, and people just are, low on folic acid. But it was a certain amount, and I believe it's 1,000 micrograms. So it's not like, it does discriminate here, meaning you could have folic acid, but you need to have a certain level, okay? And it's best to be put into food so that you can absorb it well. But it was just pretty phenomenal to see this pretty much eradicated. You see it in people that can't take prenatal vitamins, right? That they get nauseous on them, or don't have a great diet, and then they are unable. It's not like you can just take folic acid and it'll just fix it. It's got to be a couple different things, and at a certain level.
Right.
Okay. And no surgery that I've seen in utero on this. Most often unless it's that it's going to impede delivery, most often they're going to be born via cesarean section if we can see it.
Right.
There are times, however, that we get all of a sudden this baby delivers and you see this big sac coming after, and you have to protect it. It's essential. So sometimes people just don't do a level 2 ultrasound or no ultrasound at all to see these types of
and
defects.
until the child goes to surgery, the sac needs to be kept moist.
Yes.
So it doesn't dry out.
Right.
So that's an important nursing intervention. So the tube failure to close approximately 3 to 4 weeks after conception, so really, really early in development. And again, multifactorial causes, and we do know some additional factors, but again, we do think with some of the interventions that have been made over the last however many years, we have seen a decline in the amount of infants born with spina bifida. Alpha fetal protein level in the amniotic fluid, which again, we don't typically test amniotic fluid on everybody, but we would see that elevated. And we might see it on a ultrasound or CVI if it was done. But you'd need right? You'd need to be suspecting things for those tests to be done. Therapeutic management would be postnatal care of the, especially if the sac is visible, you definitely know there's going to be surgery. Depending on where the level of the non-closure is, really dictates the amount of involvement of what systems. So, you know, what are the orthopedic considerations? Is it impacting the ability to ambulate? A lot of times these individuals will have urinary issues, can't empty their bladder well. That muscle control is impacted. Bowel control can be impacted. And then the prognosis also on the level of the injury and what's going on, what else is going on. So prevention, folic acid, if there's a history of neuro defects, we increase that. Cereals and grains are fortified with folic acid. FDA required it by 1998. So thank you for all your good work, Dr. Summernes. And supplementation should begin before conception, right? So if we know that we're working on trying to get pregnant, we should be working on contraception or prevention.
Yes.
We know it, yeah.
We're all like,
I need that chapter on birth control again. Okay, you don't want to. I think, is that it? That's all we wrote. Any questions on neuro? Great, why don't we take a 15-minute break. I have it at 9:26 because I can't look at that. So why don't we come back at 9:45?
You did. I was like, what are you doing?
No, seriously?
This is making my day. The interesting thing.
My mom was mad at me. I couldn't go. Aren't you ready?
Dr. Summerness, are you ready to start again? Hello?
Yeah.
We're here.
Okay, you couldn't hear me. I was asking.
Your voice is super low, so we need the volume up.
I'm just gonna be.
Can you hear me now?
Can we get the volume turned up back?
Hello? Testing. Hello?
Yeah, we can hear you, it's just real low.
Red, yellow, blue. Can you hear me now?
Mike, can you turn up the volume?
Verizon commercial. Can you hear me now?
That's better. We are very chatty today, too.
Yes. Well, you know, it is that time of year. So we don't talk much about spring fever as a pediatric ailment, but I think it is. And it continues for as long as you're in school. So it's not an age-related thing. It's just a parameter of going through a long winter, having it be spring, having it be almost the end of the semester, and we're all excited. I know you muted yourselves. Can you still hear me, Sam?
We can hear you much better.
Okay, good. All right, so we are now going to talk about our last chapter, the child with musculoskeletal alterations. And again, these can happen from a myriad of situations, but think about childhood and how, you know, we've talked about in the past and we talked about last year, how play is the job of children and how growth and development happens because they go out and they exercise the muscles and they improve their coordination and eye-hand coordination, and they experience life and learn about their environment because they're able to move through it. And now we have an immobilized child. And so that really takes a hit on all of development, because all of learning, kind of what typically happens in childhood, when you're immobilized, now you don't have as many opportunities. You don't have as many chances to learn. So it's one of the most difficult aspects of illness in a child is having a child that needs to be immobilized, and kind of explaining to a child that doesn't want explanations that they aren't able to do something. So, you know, that and then depending on the developmental age and stage of the child, it can have varying implications, right? A infant isn't going to be worried about not being able to go out with their friends, but an adolescent and even a school-age child certainly would be. So, you know, those implications and what that means to the family in trying to make it easier for them to placate them, there's a whole dynamic that happens around having an immobilized child and really dealing with that. We have a myriad of immobilizing devices that can be used, from splinting and casting to traction. And there are two types of traction. One is skin, where you've got kind of an external device on that is then attached to the traction, as opposed to a skeletal fraction that is the kind that usually has pins and is attached to an external device. And then there are external fixation devices which may allow some mobility, but really are in place to help alignment and growth of a bone. Anytime we have an immobilized patient and we have one of those devices in place, we want to make sure we're doing a good neurovascular assessment. Right? We want to make sure that whatever device that is, it's not impeding the nerve pathways and it's not impeding our blood flow. So we want to look at skin color. And if it's a device that's on an extremity, if it's on an arm, if it's on a hand, if it's on a leg or a foot, the best way to do this is by comparing right to left. The non-affected limb to the affected limb. Right? We would expect in a typical individual with typical heart function and development and things like that, that pretty much our left and right side are symmetrical. If I'm cold, they're both cold. If they're hot, they're both hot. The pulse rate should be similar. The strength of the pulse should be similar. All of those things. So we look side to side. And we look at skin color. We look at cap refill time, temperature of the limb, sensation. Are they able to feel? You know, when I do this, can you tell I'm touching your, and, you know, of course it's best to have somebody look away, but, you know, tell me when you feel me tap your toe. Tell me when you feel me tap your finger. Are they able to move digits and toes? And is there a pulse at the extremity? So, you know, do we have pedal pulses? Do we have a radial pulse? Those kinds of issues are going to ensure that whatever device we're using, that it's not impeding, like I said, either our neurological status of that limb or the vasculature. Here's a little one in some traction, and that would be internal traction. You can see just above his knee, he's got some pins coming out of his leg that are attached to that kind of horseshoe-shaped device, and then it goes up and over and supports his leg that way. And so really here, his foot is almost acting as a counterweight in this device. But we also have some toys in the bed with him. It looks like he's actually in a playroom. Because there's another young child there, and there's you know, some drawings on the wall. This doesn't look like a typical hospital room. So with children, we will, if there's room, we will wheel a bed into the playroom, depending on the size of the playroom and the accommodations that can be made. But remember that, play is important, and getting into a safe space, right? Their room is a safe space. If we're going to do anything that's going to be painful, we'll take them to a procedure or treatment room. But by the same token, getting out of the room to that area, if there's an outdoor little roof deck park or something like that, and they're able to do that, but something to change their scenery, something to kind of give them a different view, and to make sure they've got toys and things to stimulate their creativity and their activity. The effects of immobilization are just limitless, really. We've got, we know that when we're immobilized, when we're in bed for a long period of time, tends to slow down our metabolism. It can slow down our cardiovascular system. We could have edema and kind of pooling of blood in different areas of the body. It impacts our respiratory system. We're not up and moving around and running, so we're less likely to be taking those good deep breaths. It can slow down our GI tract. It impairs our muscles, right? We know that it doesn't take very long for our muscles start to kind of lose their tone. Right? If you're in bed for 2 or 3 days and you get up out of bed, you don't feel like going out and running a marathon. You feel like, oh man, I've got to get this back. It can impact our skeletal system, the urinary system, integument. If you're immobilized, now that splint or that cast or that traction could be causing friction points where we don't normally think of them. So when you see a person with a cast, remember that there's friction points now, not necessarily just over bony prominences, which is, I think, what we think about when we think about an immobilized person. But is that cast rubbing? And is it creating breakdown, under the foot? Or do we need to kind of pedal it with some moleskin or something so that there's no sharp edges? Things like that. So really being concerned about all body systems and how immobilization can impact them. Immobilization of a child impacts the family. It disrupts the family's daily routines, right? Even if the child is able to go to school, what used to be, a 45-minute, let's get everybody ready and out the door to the bus, now takes an hour and a half to get him dressed in the clothing, because getting anything over that cast he can't do himself and he needs help. And now we've also got to drive him to school because he can't get on and off the school bus. And we've got to make sure that they've got a note that says they can't go to gym class and that they can't do things like that. So there's a lot of coordination and things that need to happen. Logistically, that family needs to figure out these things. If the family doesn't have a car, how can that child get to school? Can the school district provide transportation? What's available? All of those kinds of things are things that the family will have to deal with, and out of the blue in a lot of times, because a lot of times this immobilization is from a traumatic event. I was climbing a tree and fell out and broke my femur, or something like that. So it's not necessarily a planned event that you can say, oh yeah, I was pregnant and my parents were going to come a week before I was due to deliver, and they were going to stay for 3 or 4 weeks to help us with the other children and do all these kinds of things. You don't necessarily have that window of advanced planning. You may need home assistance. And if you remember from when Amanda and Brooke were here, sometimes having people in your home is not just like, oh, this is great. Well, it is great because you need that help. But it's also somebody in your home for extended periods of time. And what does that feel like? It can be the best situation in the world, but it's still having somebody that's not a family member visiting, but every day for, bless you, for a long period of time. So even coping with that, as much as individuals may know they need that assistance, that's a huge change for the family to deal with. And then coping skills for the individual with the injury, for the Parents, if they're having trouble coping with whatever's going on, is also recommended. So as we said, traumatic injuries are the most frequent that we may see in childhood, and they can, involve sprains, strains, fractures, the gambit. And we really see all with our pediatric population. They can result in, as I said, falling out of a tree when you're just kind of having fun, sports injuries, and we know that there's a huge effort now around concussions and sports injuries and how to keep our kids safer. And we know we're learning more about the impact of having multiple concussions, even if they don't seem that severe, that they build on one another, and that can be problematic. So really, watching for these things, treating them, and understanding the mechanism of injury and what it takes to recover. Types of traumatic injury: contusions, bruises, right? Dislocations. I hate seeing dislocations. To me, they just make me want to run away. And having been an athlete, it's like, a dislocated knee or something is just horrible. But kids get dislocations, they get sprains, they get strains and fractures. So we do see the gambit. Remembering that if it's a child that's not mobile, and they have odd kind of injuries, we think more along the lines of perhaps maltreatment, because it's not real typical for them to be kind of doing activities that would show certain kinds of injuries. So we always want to take a good history from the child, an adult that was with them, about, well, what happened? How did this happen? And really assess whether the injury we're seeing corresponds with the story they're telling on how they got injured. So if I was playing baseball and I got whacked in the head or whacked in the stomach with a baseball bat, and I'm seeing bruising here, I'd say, yeah, okay, well, if you're telling me you ran into a door and I'm seeing bruising here, maybe not. That may need a little bit more investigation. So does the injury and the story make sense? And does the story not change? Soft tissue injuries, rice and ice. So we want to rest that injured part, ice it immediately. You want some sort of a protective towel or something between the skin and the ice. You don't want ice directly on the skin. And for a max of 30 minutes at a time, every couple hours. A compression bandage, if recommended, may help eliminate swelling. A lot of times, if there's a bad injury that has swelled a lot, we can't actually go in and do surgery until the swelling's gone down. So that takes a couple days for swelling to decrease before further setting and repairing of that injury can occur. Elevation, again, to prevent swelling, and immobilization and support. So casting or splinting is appropriate. You may expect for soft injury, tissue injury. Fractures are a common result of injury in children, and kids' bones heal real quickly, and so that's the upside. Where we might be in a cast for an extended period of time, a child might need a cast for 3 to 6 weeks. So they do have injuries, they do have fractures, but oftentimes the healing of that fracture occurs quicker than in adults. Fractures, again, rare in infants, warrants investigation. Distal forearm is the most common fracture site. And for school-age kids, bike-related sports injuries are the most common cause of those injuries. I started kindergarten with a broken arm. And so I can relate to bike-related injuries, and it was of my elbow. So it was a fracture of this, and I started kindergarten. I'm in a sling, and fortunately I was left-handed anyway, so it did not impede my beginning academic career. But how many here have had a childhood fracture? Not too many. How about in Twin Cities? Now I can see you. Okay, thank you. Good. A little bit higher percent of Twin Cities students than students here, but it's not uncommon for kids to have fractures, to have falls, to need stitches, and those kinds of things. But we always do take a good history and then do an assessment. Types of fractures, simple or closed, is a fracture that doesn't break the skin. An open or compound one is where you will see the bone through the skin, so there will be bleeding as well. A complicated fracture is fractures where the bone fragments or disrupt tissue or an organ, so those would be complicated. And the fourth one are small fragments in the surrounding tissue. So there are different types of fractures, and certainly a closed fracture is the least complicated, although it may still need to be pinned. So the good news, again, typically rapidly healing in children, neonatal period, 2 to 3 weeks. So these would be children that maybe incur a fracture during the birthing process. So they would have a neonatal fracture, and we would expect those to heal very rapidly. During childhood, as we said, 4 weeks in really early child, so, in that 4-year-old, 5-year-old, probably 4 through 7-year-old, and then later childhood, 6 through 10, maybe as much as 6 to 8 weeks. Adolescents, 8 to 12. So, and that's a good thing, because can you imagine a 4-year-old in a cast for 12 weeks, 3 months? I mean, that's a long time to be restricting activity of that child, and the child is going to feel like they can do anything. So they are going to want to be up climbing the jungle gyms and doing anything and everything that is possible. So kind of reining that in within reasonability and controlling that child's activity so that they don't injure or harm themselves more is important. Diagnostically, x-rays, typically for fracture diagnosis, and then, like I said, a good history taking. And the goal of fracture management is to reduce the fracture, so to line the bones up to how, so that they will be straight, immobilize, restore function, and prevent deformity. Right, so we want the bones aligned well so that we now don't have, a forearm that takes a 90-degree angle at the point it was broken. So we don't want it healing in an awkward position, and we don't want it impeding on muscles or bones, or muscles, ligaments, or tendons, or the nerves that could impede then the function of that extremity. So it's setting it so that it's in proper alignment, and then restoring function once that immobilizing device is eliminated. When we're assessing fractures, we can think about the 6 Ps. So where is it painful or the point of tenderness? And we can ask the patient to show us or point to that. Dr. O'Connor-Vaughan talked about the body picture, and they can make an X where it hurts, something like that. And we want to look at that area last. So where it hurts is the last thing we're going to do, because if we're going to go towards that, if we're going to touch it, that patient's going to be tense, they're going to be nervous. So we say, I need to do an assessment, show me where it hurts. Okay, I'm not going to touch that right now. And when I do go to touch it, I will tell you so you know. And then that's what you do. And then you assess the patient's pallor, pulselessness. So comparing, again, do your whole non-injured side and then go to the injured side, but pulselessness, paresthesia, paralysis, and pressure. So those are the 6 Ps. You need to look at them, but again, I wouldn't go directly to the point of injury first, do everything else, and then the injured area. Casting, spica cast here for mobilization of the hips and legs. And this is a rather challenging device. Kids do go home with this device. They can be in the hospital with this device, and they basically are immobilized, but the upper body should still be kept strong, so they can be doing a lot of different things. Urinary and bowel function should be watched so that we keep them dry and clean. Here's a little guy with his arm cast, and again, you can see he's able to, on his the casted left arm, his fingers are bent. So, if I was assessing him, I would say, can you wiggle your fingers? And then I would want to be assessing kind of under that cast, taking a look at the skin under both where it comes across the fingers and where it comes across the top, and asking him about it. That kind of looks like a plaster cast, and we don't see plaster casts hardly at all anymore. Typically fiberglass, and you can choose the color and all those kinds of fun things. So, any questions so far? All right. Tractions for fractures in children. It's mostly a balanced traction that's applied, and this is done so that the bone is well aligned and not kind of pressing one end against the other. So if you think about the femur, for example, there's a fracture in the femur. We want that femur to align so that the proximal and distal ends are together, but we don't want them to be have a propensity to slide against one another. So at the upper end of the femur, the patient's body is stabilizing that area, and we put traction on so that it's also stabilized at the bottom of the bed, and that bone is aligned. And so that's how you'll see traction to allow that physiologic stability. It can align bone fragments and enables closer evaluation of the injured site. So this may be done while we're waiting for some swelling to go down. This may be a way to immobilize that joint or that bone, that fracture, in order to stabilize the fracture until we can take a better look at it and decide if it needs to be casted or pinned or what. Fixation devices are a newer technology that kind of do the same thing. So the purpose of traction, when you think about a broken bone, you know that the bone's broken, but what happens to those muscles and everything around it, right? They're tight, they're contracting. And so traction can help relax those muscles so that you don't get contractures there. As I said, it positions the bone, it immobilizes the fracture, it can prevent deformity by ensuring good alignment. And that immobilized healing bone and prevent further injury. So we're not going to see a re-break or something like that. And it can reduce muscle spasms by allowing those muscles to relax. And here we see kind of just a picture of what I was describing with the counter traction. So pulling backward force, and then the traction is the forward force. And it would help to align this bone and keep it immobilized. There are a lot of different kinds of traction, and I'm not going to say what's the difference between Russell and Buck or things like that. Know that there are external devices and internal devices. And so if I have an internal device, it's going to have pins, and it will require pin care and things like that. But the nature of why we're using the traction and how we're using the traction, that's what I'd like you to know and understand. Buck traction is an external traction, and here we see it's kind of a brace around the foot and leg that then has weights pulling on it. And it stabilizes the foot, and then the patient's body is acting as the counterweight. This is a halo traction. You may have seen these in pediatric patients or adults, and typically with cervical spines. Again, it's maintaining the alignment. It's prohibiting, it's immobilizing the head and neck so that they don't re-injure the head and neck while they're recovering. And again, you can see pin placement on these goes into the skull. Sorry. Distraction of a fracture is the terminology that's used for separating that bone to encourage regeneration of a regeneration of bone to repair the fracture. And so it can create new bone. It can also be done to a certain extent if in a leg lengthening procedure where you can create a fracture and separate those bones, and then new bone will generate to try and increase the length of, so if you've got one femur shorter than the other, you can try and increase that. And that's typically an external fixation device that that would be a longer term intervention, and they would have that on for a longer period of time. And so here's a little girl, and she's got her external fixation device on her right lower leg. And so this is helping that leg lengthening to occur by regenerating the bone and that would probably be in the tibia. So one of the risks, anytime you have an internal fixation device, so a device with those screws that go into the bone, there is a risk of osteomyelitis, an infection of the bone, and that can be a long-term antibiotic treatment. The device has to be removed, so now if you were repairing a fracture, that becomes a much more extensive procedure. And staph is the most common causative organism, and of course we know that we kind of live in a staph world, and it exists on our skin and all over. So really seeing that we care for those and really do good care, skin care and pin care is a must. And so osteomyelitis signs really quick, good one day, not good the next, and it can resemble kind of the symptoms of arthritis or leukemia, marked leukocytosis. Bone cultures can be done, and they're not real fun either. And x-rays may appear normal at first. It may be a CT, or you may see some involvement of soft tissue surrounding on bone scans. And so you would want to see, is it an abscess that's kind of walled off and in and of itself, or is it throughout the entire bone? And really, it's pretty significant IV antibiotic therapy. 3 to 4 weeks, up to several months, and I would say 3 to 4 weeks is really the minimal, and you're probably going to see longer than that because it's difficult to treat. And then because it's these, long-term antibiotics, you're going to be wanting to monitor renal, hepatic, and hematologic response to make sure that they're not getting a toxic response to the antibiotic and going into renal or liver failure. And so care, now you've got a patient that they might have had an external fixation device that allowed them to walk around, some mobility. Now they're on complete bed rest and immobilization of that limb. They're going to be in pain, so now they need some pain management on board, long-term IV access, so a PICC line or something for the IV administration, nutritional. Are they eating? Are they well enough to eat and take in fluids and things like that? What can we add maybe to their diet to promote healing? So maybe they were on one diet, but a nutrition consult to say, we need this person to be in now optimal healing. Are there things we could be doing? Definitely PTOT once they come off of, once the limb is healed, because they will have been immobilized for a long period of time and may need some exercises to restore that, that limb to its full function, full range of motion, good muscle tone. And what psychological needs might they need, and depending on the age, what school needs might we be able to attend to? Some hospitals actually in their children's hospital or on their children's units have a teacher on staff that you can get the lesson plans for the week, and that teacher will come in for a couple hours a day and one-on-one go through so the child keeps up. That's typically for if there's a long period of hospitalization, but if the child's going to be in the hospital for a longer period of time, something definitely to consider and see, how can we work that out? If you've got a really high-tech school district, they may have a robot that can be rolled up to the student's bed with ITV. And, they can be part of the class while they're in their hospital bed being immobilized. So, depending on where and what resources available, different things can occur, but they don't occur without people thinking ahead and planning and putting that into motion, having the parents think about, reaching out to their school district and things like that. Juvenile idiopathic arthritis is another musculoskeletal problem that children might have. Peak onset is really young, 1 to 3 years of age. So that's when you think about kids, they're just starting to move around and things like that, and now they will start having painful events related to that movement. And a lot of times it's not diagnosed because it's hard for a 3-year-old, a 1-year-old to tell us what's going on. Possible causes, really not known. It may be an immunoresponse with environmental triggers, but we don't really have a hard and fast cause determined. And actually, we look at it as kind of a grouping of disease when we talk about JIA. So, usually it has a systemic onset. So it's not just of one kind of thing. It's a high fever with rash. We'll see an enlarged spleen, some pericarditis, pleuritis, and then we can see it involving, less than 4 joints. We can see it involving more than 4, and it may be a type of psoriatic arthritis that we see. About 90% have a negative rheumatic factor, so it's not diagnosed easily by labs. And it can be a kind of relapsing and remitting. So they may have it exacerbate, and then it can kind of go away. And so you think, okay, that was we don't know what was going on, but they seem well now, which adds to some of that confusion with diagnosis. And in a chronic inflammation state, we see joint effusion, so swelling of joints. They may look red, destruction of cartilage, and things like that as the disease progresses. They may have an elevated sedimentation rate, leukocytosis during exacerbations, but not when they're remitting. And the diagnosis is based on criteria by the American College of Rheumatology. I don't know that I've ever seen a couple of kids with JIA, but not in the hospital, in the community. There's no specific cure, and again, the goals of therapy, we want to maximize function, prevent deformities, so as and I've got some arthritis in my hand, so I keep on doing this. As function gets limited, we want to try and give exercises and things that can maximize maximize function. Non-steroidal anti-inflammatories, slow-acting anti-rheumatic drugs, corticosteroids. So you're kind of trying a different levels of things to see the minimal amount of pharmacologic intervention that's needed to stabilize the rheumatic outbreaks. And again, pain relief, huge in this population of children. Facilitating compliance and promoting good general health. Physical therapy and occupational therapy is needed to maintain range of motion and ability to perform tasks. Heat and exercise are helpful, so you don't want to coddle this child and say, oh, you know, don't do things. The more they do, the better they'll be. And support of the child and family, because this is a miserable disease. It can be progressive, and we just supportive care all the way around. So now we've got Kristen, 10 years old, sustained a fracture of the epiphyseal plate when her right fibula when she fell out of a tree. When discussing the injury with her parents, the nurse should consider that healing's delayed in this type of fracture. Bone growth can be affected by this type of fracture. This is an unusual fracture in young children. This type of fracture is inconsistent with a fall. Which do we? Who thinks it's A? B? C? D? I missed the consensus here in there in the Twin Cities, but the consensus here is B, bone growth can be affected because it was sustained in that epiphyseal plate. So we know that epiphyseal plate controls bone growth, and when it closes, so if that's been fractured, it can affect the type of it can affect that bone growth. And that's the end of this one. Oh no, yes it is. That's the end of that one. It is 10:30. Yep. Dr. Summerness.
Yes. Okay, what I think we need to do is, I do have both of the Cahoots brought up from a couple different weeks from last semester, but I'll run it from here most likely, and then you can, Dr. Beacham, you can, as the answers come up, you can offer, and both of us can offer what the right answer is and any questions. How does that sound? So we're going to have to switch to my computer that I've got up.
Okay, let me...
So I'll have to go from here. Does that sound okay?
Yeah, let me put forth another option, because they're not going to take an hour and a half. Am I correct?
No.
Okay. I will give the alterations in hematologic function lecture.
Ah.
All 15 slides.
Oh, there's just a few. Okay.
As opposed to making a voice thread. And
Okay,
that
well,
way we're all good.
That sounds
I'm getting
good.
thumbs up here. Are we getting smiles in the Twin Cities?
They are smiling, actually, each one of them. Look at them all. They are. They're really happy. They're like, I don't have to wait for that. I'm just so excited.
Joy. What's
The
that?
joy is,
I was going to say it's palpable. I can feel it here.
it is everywhere.
Yeah. Anyway, so let's do that, and then we'll all be up to date and good, and then I don't have to carry the burden of doing that voice thread or finding one, and I think we're all in better shape going into next week's exam. So, hematologic alterations. When we talk about the hematologic system, we're talking about our red blood cells. This is totally kind of flip-flopping And so, you know, we're thinking about our bloodstream now, right? We're thinking about the hematologic system, and we're going to talk about the anemias. We'll talk about some iron deficiency anemia. We'll talk about sickle cell anemia, and yeah, go from there. I think those are the two big ones we hit on this lecture. So our red blood cells carry oxygen, right? Carry iron. They're really good. They're important for us to have, right? And so that we rely on them. They vary according to age, sex, altitude, and so the ability of our red blood cells to carry oxygen is dependent upon sufficient circulating iron. So, you know, a lot of things are kind of tied in together and really take the complete picture in order for us to maximize the amount of oxygen our blood carries and its ability to carry it to all areas of our body. So what happens when we're deprived of oxygen? What happens to our cells? I heard they die. Yes, they do. I'm not looking for a medical term. Dying is sufficient. They die. And so if those cells are in an organ, that organ begins to die, right? So if it's our heart, if our heart's not getting enough oxygen, we have a myocardial infarction. If our brain's not getting enough oxygen, right? So if we've got a bleed, or if we've got so an aneurysm that burst, or if we've got a blockage, a lot of plaque buildup, and now blood's not getting to an area of the brain, we can have a cerebral infarction, more commonly known as a stroke. And children get these. One of the reasons we give vitamin K at birth is because infants, or neonates, newborns, are at risk for brain bleeds. And so the vitamin K, through its clotting properties, helps prevent those. So when we're caring for children with hematologic disorders, we need to understand the anatomy and physiology of that blood. So what's its purpose? How does it get places? What happens when it's blocked getting places? What tissues help form blood? The genetics behind some of the associated alterations in hematologic function in our children, and some of those chronic illnesses. And so one of those, I said, was anemia. So anemia can have some very different causes, right? If we have blood loss, if we've been in a traumatic injury and we've lost some blood, we can be anemic. Females who are having their menses tend to run a little bit lower on and be anemic and have a need for higher iron stores. We can have decreased production of red blood cells or hemoglobin, or we can have increased destruction of those RBCs. So we can either not make enough, or they can be dying too early, and we can be anemic. With our children, iron deficiency anemia is one of those conditions that we are mindful of. And one of the reasons is because, we know that they need iron. And the way they get iron, when we think about our infants, up to 6 months, it's totally breast milk or formula, right? So they need that iron. Cow's milk does not have iron in it. And that's one of the reasons why we say no cow's milk until 1 year of age. Because at 1 year of age, they should be taking enough other nutrients to be getting iron-rich, iron-fortified cereals or things like that will make up for the iron that they might not be getting through formula or breast milk, and then they can be taking in cow's milk. But cow's milk does not have is not a rich source of iron.
Can I say something?
Sure.
So additionally, it's also something that we have to remember that the cow's milk and any other animal milk might have a significant effect on how babies tolerate that. And so something that I share with people, we're the only animal really that drinks another animal's milk, right? You wouldn't go see a goat, drinking a cow's milk, right? Or go and doing that kind of thing. So we do have a reaction. We build up a resistance here a little bit, and we can break it down. But there are many people that end up being possibly lactose intolerant or different things, because the gut is affected. So just something to keep in mind about those types of things. And more we're seeing studies around early introduction of cow's milk into the gut has some potentially harmful effects. And some people don't have any other way, but there are different types of milks that can be offered. If you still even have to give milk at 1 year, most people it's more of a comfort item rather than really a nutritional item. And it's very filling, especially whole, 2% are whole, so they won't eat the nutrients that they actually need to. So the AAP is kind of...
and once a child starts taking other forms of nutrition as opposed to liquid, it is important that they take in the food items before either breastfeeding or formula feeding or whatever, because you do want them to get the nutrients from the food items as opposed to filling up on formula and then not taking in food. Yeah, great. And so as nurses, again, a good history taking, there's really no substitute for a good history taking. Good history taking can lead you down the road to, what's really going on and things like that. So honing the history taking skills is really important. That physical examination, family history. So is this something that seems to be a familial propensity? And I think lactose intolerance sometimes does show up in families. Known results of labs. So you would expect to see a CBC, serum ferritin and serum iron levels. And so making sure you're following up and finding out when those labs are available, what those labs are. Parent teaching of the causes. So again, why the history is so important is because based on the history, we would know this if this is a dietary issue, right? So if what they're doing is perhaps not getting enough iron in the child, they've switched to cow's milk for some reason early on, we would recommend going away from that. So that history and then the parent teaching can really tie in nicely together. Dietary management and an iron supplement at home. And remembering that, again, anytime you're giving a medication prescription or anytime you know that that family's going home with a prescription, if we can model for them how to draw what the amount looks like, because it's going to be a very small amount of an iron supplement that this infant would take. But they're going to get a bottle of it. So overdosing would be fairly easy. So making sure that the parent can do a return demonstration kind of thing on, a teach back on how I would draw it up and how much goes in, just a little bit of what, or how I give it to the side of the mouth and those kinds of things. Iron fortified formula or supplements, if they're older than 12 months and they are drinking cow's milk, and I totally agree with Dr. Summerness, and the science is supporting this as well. We don't need to be drinking cow's milk, and so there are other sources, and breast milk and breastfeeding, I think, has a lot of benefits over time and over 12 months. A bottle is probably less therapeutic in, some ways of comfort and things like that. So getting them to a different formulation, whether it be almond milk or soy milk or something like that, and maybe even to a cup early, a sippy cup or something like that, can be helpful in a lot of ways. Iron-rich foods, meats, green leafy vegetables, my favorite answer. And vitamin C to increase the absorption of iron. So again, it's all working together. Yeah.
Like not bad for babies because it has like estrogen in it.
You're right. I don't know whether I would, I would have to follow up on that. But alternatives are certainly viable. Any other questions on iron deficiency anemia? And then our sickle cell diseases are really a group of congenital diseases. Sickle cell really causes the change in the nature of that hemoglobin where they're misshapen. And so instead of it being a nice round cell that's easily movable through vessels, it's misshapen, and when the individual becomes dehydrated, when the cell becomes dehydrated, it tends to look more like a sickle, like almost like a crescent moon. So it's got points, and it's easy to get stuck as it's trying to navigate through capillary beds. And so when that happens, when those cells get stuck, it creates an ischemic event in that area. And those ischemic events can happen anywhere throughout the body, right? Because our blood's going everywhere throughout the body. So a lot of times we think of sickle cell with pain, and absolutely that is true. But when we think of that pain, we have to think of that pain in relationship to there are organs and there are areas of the body that aren't receiving oxygen. And so this really is a medical situation that needs to be managed. Treatment of pain with sickle cell, non-steroidal anti-inflammatories, and hydration is pretty much part and parcel level 1. And this will be done at home, right? If I am an individual with sickle cell disease and I start having a pain crisis, or there was a little girl in the hospital that I took care of that knew when she went swimming, because the water was cold, she would have a pain crisis, but she loved to swim. So they would make sure that she was really, really well hydrated and give her a non-steroidal anti-inflammatory before she went swimming to try and allow her to do her activities and yet not have a pain crisis. If I'm experiencing pain and the non-steroidals don't take care of it, I probably have opioids at home to take to manage my condition, because that's a lot of times what it takes to break the pain. So when I come to the hospital as an individual with sickle cell disease and say I'm having a pain crisis and say I'm in pain, and it's really important to say, what have you done so far? And if that individual or if that child has already taken nonsteroidals and their PO, morphine or opioid, whatever they're ordered for pain, and it hasn't worked, if I come to them and say, oh, here, the doctor ordered 2 Motrin, what do you think they're going to do? Throw it back at me. Probably. So getting a history, what have you done so far, what's helped in the past, and treating that pain is really important. And a lot of times they come in because they need IV pain relief. They need IV hydration. And that's what you'll see our kids on. And I think I told you the story about the little guy who had a PCA and didn't realize that it was actually giving him the medication. But IV hydration and IV opioids to get over that pain crisis, because that pain means that there is organs, muscles being occluded. There are a certain percent of pediatric kids that also have higher incidence of mini strokes, mini cerebral infarctions. Over time, because they have these pain crises, and we never realized that it was impacting their brains as well. So, really treating, and then there's some other things we can give to try and improve their status. Blood transfusions can be given, and a lot of times children are given blood transfusions like once every 3 weeks. The idea is if you give them blood without sickled cells, so blood with whole red blood cells, it decreases the amount of sickled cells as a percent of their total blood volume and will kind of help minimize the impact of those sickled cells. I've seen it every 3 weeks. This has gone on for, to some kids, that's what they were doing for, And in that case, the clinic that was doing those had a teacher, and the child would, because they would spend the day. By the time they got their blood work done and got the, blood from the blood bank and got them set up and so that was an all day once every 3 weeks. That child missed school to be there getting their transfusion. Splenectomies. When you think about the spleen, blood rich, right? Lots of blood in the spleen. Lots of blood gets caught in the spleen, and a lot of pain and a lot of splenetic enlargement and rupture. So a lot of times these kids will have a splenectomy, and they will just be without spleens, which makes them more susceptible to infection, which is not good because that can exacerbate a sickle cell crisis. So you want to administration of blood products. You, as with adults, baseline assessment. You want to ensure the rate of infusion is not too fast. Monitor closely for adverse reactions. And in a child with sickle cell, because they've had multiple transfusions, they may have multiple antibodies to different things. So really monitoring them for a adverse reaction is paramount every time, because it's not like they've gotten, this is my first blood transfusion and I've never gotten one before. And if we suspect a transfusion reaction, immediately stop it, notify the provider, because there could be some an emergency situation. Prophylactic penicillin till about the age of 5. This is because they're still really, really small, and we don't want them to get any major infections that could impact the heart and things like that, so we try and keep them healthier. For individuals that are on multiple transfusions, so for that child that's getting a transfusion every 3 weeks, the iron chelating drug pulls iron from the bloodstream because the risk when you have so many blood transfusions, one on top of the other, is that now you've got too much iron, and iron at that level can be toxic, so we need to pull some of it off of the blood. Hydroxyurea is a really cool chemotherapeutic drug. It's a drug that stimulates the production of hemoglobin F, fetal hemoglobin. And so what's cool about this, when we look at kids with sickle cell disease, we typically don't see any signs or symptoms till about 6 months of age. And that's because when you're born, you have hemoglobin, adult hemoglobin, but you also have fetal hemoglobin. And that fetal hemoglobin kind of dissipates slowly till about 6 months of age. And when there's fetal hemoglobin on board, it is the thing that's diluting those sickled cells to have them be less of a percent of the total blood so that you get less signs and symptoms. When that fetal hemoglobin decreases, you start seeing signs and symptoms of sickle cell. You may see, and one of the first things is the dactylitis, so inflammation and swelling of the finger joints. And the earlier it happens, it seems to be the more severe that child's presentation of sickle cell will be. Hydroxyurea stimulates our production of fetal hemoglobin. And so they take hydroxyurea and it increases the amount of hemoglobin F as a total percent of their blood. So it, by virtue of that, decreases the percent of sickled cells they have in their bloodstream and decreases the amount of events due to sickle cell disease. And then there have been some cases of stem cell transplant that have, by reports, eliminated sickle cell from the individual. Kind of a good picture of typical red blood cells are nice and rounded, and here we see the abnormal, we've got some typical cells, right, because not every cell is sickled, but the ones that are, we can see where they're not that nice hydrated cell that looks like it's just going to kind of slip and slide down the slide, but it's the board that you're going to try and get down the slide that's not going to be able to make that turn. And you can see here internally there's some just differences between the cross-section of a typical RBC and a sickled RBC, where those strands are what kind of has the cell collapse on itself. And we can see that when there is a vaso-occlusive crisis, it's a painful episode. It can be an acute chest situation where there's blockages for the chest, and so they're having respiration trouble breathing, painful breathing and pain on their chest, the painful swelling of the hands or feet, the dactylitis, priapism, an erection in males that is will not subside, and it's very painful, and a CVA, a stroke, cerebral vascular accident. Acute sequestration is what it's called when there's when the spleen is engorged and because of the blood backup, and an aplastic crisis can also occur. So for our nursing assessment, after that good history, we want to assess pain. We want them to rate their pain, tell us where it hurts. A neuro assessment, because we know that there could be sickling in the brain. So do we still have good neurological function? Is there a fever? Are we suspecting infection? How are they, what's their O2 sat? How's their breathing? What's going on there? So really doing a head-to-toe assessment fairly rapidly, but looking at all of those situations that may give us a clue as to where this pain is and what systems may right now be affected. And so we want to increase our tissue perfusion. So hydration can help do that. Control pain, because we know that if we're in pain, we're tense, our muscles are tense, and we're not perfusing as well just due to that hypertensive state and the hyperflexed state of our muscles. And we want to prevent infection. Sickle cell is autosomal recessive condition, so that when both parents have sickle cell trait, what's the chance that the child will have sickle cell disease? 25%, A, right? Both have the trait, so if you do your box, it will come out. But autosomal recessive, if they have the trait, it's 25. It changes if one of the parents has the condition, because you have to have both with the sickle cell trait. Any questions? Question here. Yes.
For like a sickle cell crisis, I know we talked about hydration for increasing tissue perfusion. Is that the only way you can really like
oxygen?
Oxygen.
And you may see some of the pain management. It's kind of multifactorial, but yeah.
Okay.
Yeah, it would be. The hydration is going to help get the blood there. O2 is going to help better oxygenate. Pain control is going to help with everything.
Okay.
Okay. Question?
Do we need to know what an aplastic crisis
No.
is? I didn't catch that. Okay.
Questions? Is there a hand up in Twin Cities, or is that somebody stretching? Hand up, yes.
Had sickle cell disease and not the trait, would it be 50% then, or?
Oh, I don't have it here. XX X. Okay, I just got really confused. I will get back to you on that. I have to do my box. And I don't have something to write with. No, she said if one. It is 50.
One had it, one had the trait. It would be 50. If
One
one had it and one didn't have anything, it would be.
If both have the trait, it's 25%. If one has sickle cell and one has the trait, it's 50. If both have sickle cell, it's 100%. Thank you. Thank you. Anything else?
Isn't it protective, kind of like the
Else? I don't think so. We're chatting, but any other questions?
Okay. Somebody here is protective of, asked if the pain is protective.
kind of like it can have the and then the medication, you want to make sure they don't like have any withdrawals or like some blood clot alter their
If it's an individual with sickle cell, you would do your assessment, and you would not be the only person doing an assessment, but I
if they're like out in the community and they have like pain, would they like take medical attention or would they just take their opioid?
it's kind of like your asthma action plan. It's kind of like if you're having your sickle pain, and you typically know what your sickle cell pain is like as compared to other pain. Your first is, make sure, drink some water, hydrate yourself, and take the anti-inflammatories. If that hasn't helped after a period of time, continue the hydration and take a dose of and if that hasn't helped, seek medical care.
I was at this lady's house.
Hey, folks.
Sickle cell.
Uh-huh.
First time being introduced to her, this lady was probably way 20 years old. She was in a fetal position on the couch in serious pain. And it seemed like nothing you can do for her. And I don't know if she was doing that every. That's why I said, how long did they do this blood transfusion? Because you can tell something. Patient that was getting transfusions, you could tell something in her arms. Her color was like off to blotches.
Yeah, no, I mean, we're doing a lot better with sickle cell management. When we think about pediatric chronic conditions like sickle cell, like cystic fibrosis, and some of the other conditions, 40 years ago, you didn't live into late adolescence. Those were kind of conditions that were really life-limiting for individuals. And with, childhood diabetes to some extent too was extremely life-limiting. And now with a lot of better interventions, better understanding about the dynamics of the disease and the treatment of the diseases, we have really extended life well into middle age and beyond. So, yeah, it's and there's always, new things coming around the corner, like the stem cell to treat sickle cell, and things like that. So, I think with that, we will end. Oh, I have one more question here.
I got a few about the test.
Oh, we've got questions about the test.
We're just going to ask as many questions as humanly possible on our last day of class. That was the plan today.
Hey, it's fair.
Well, you want who first, and then we can do other questions?
If you want to.
Well, okay, ask your questions.
So in ATI and McKinney, we saw a lot of diabetes insipidus, but that's not on the syllabus. Do we do just diabetes 1, focus on that? Or?
Yes, your map for the final is the objectives for each of the units in Canvas. And where I say focus on,
Yeah.
that's kind of a little hint to be, 90%, 95% of this unit questions are going to be on this material. Now, I will never say that there may not be one question on, and I'm not even going to say diet, but on something that's not specifically there, but it shouldn't be like, oh, I didn't know, 45% of the things weren't covered on the, that's your pretty much guideline, and I have committed to giving you a better, a little bit more detailed map to the exam, as opposed to just saying endocrine systems, 6 questions. So I will kind of reiterate where the focus is.
Okay. And same with like Wilmer's tumor.
Don't care about
Sorry
it.
about that.
Yeah. No, and I mean, I care about it.
Chapter 39 is all that it's on.
What's that?
Confusing. Like chapter 39 was assigned to read, and like that's all it covered, but it wasn't on our stuff, so it was real confusing to like know if I'm supposed
Well, for ATI, because here's the deal. I have you for 6 weeks of lecture.
Right.
I can't give you every condition of every system problem in pediatrics. I'm going to key on the ones that I think are most likely that you're going to see on NCLEX and that you should really know about, broad-based for a foundation in pediatrics. If you want to be a pediatric nurse, and the thing is, it's all information. So is it good to say, oh, I've heard of Wilm's tumor and it's an endocrine thing, and, so that if it is an NCLEX question, you're not kind of timed. So I don't teach to the test, but yet I can't include every single alteration and thing. Otherwise, all I'd be doing was throwing up, and look at this, and look at this, and look. So I try and give you the overall things to think about and how to work out, so that when you get a question, you'll be able to say, oh, it's endocrine, and then, maybe some of the answers don't have anything to do with it. So that's kind of the method of my madness.
Okay, I think these ones were on
Do we need to know cardiac meds?
Meds?
I would know digoxin, I would know diuretic. I don't care about what the med is called as much as perhaps knowing why I'm giving it. So if I've got a kid with right-sided failure, what am I going to see and what might I give, versus if I've got left-sided failure. Make sense? So it kind of in that context, but I'm not going to give you, here's 10 meds. I don't even know, but another question here in the back.
Do we have to know the different type of surgery for different type of cardiac?
No. You would need to know if there's a surgical intervention, but you're not going to need to know what that surgery is called or that kind of thing. So if a person has a ventricular septal defect, I want you to know that that can be repaired, and that's what should happen. Yeah.
Do you know what the study guide is going to be out?
I am hoping by Friday. I have a class tomorrow morning, and then I hope to get to kind of doing those.
I have 3 more, I'm sorry.
3 more questions, okay.
Hemophilia?
Hemophilia. I don't think so, but I would know hemophilia effect. What's that?
It's objective. Can you just maybe explain a little better what it is? Or did we miss it on one of our?
You can read. I mean, like I said, it's like hemophilia, factor 8. I don't have it. I need to get it. The kid's at risk for bleeding, so that anytime they fall, it's a medical intervention for the family.
and neoplastic disease.
Don't worry about that.
Oh, and then child versus adult endocrine is the other one. One of the objectives to know the difference between child and adult endocrine systems is just that they're like, oh, I don't know if there was something I was missing as well.
Well, I think with endocrine, we worry about growth and development far more than we do with adults. So I think we went through some of that in those slides. Anything in Twin Cities? Questions?
None.
Other than what questions 1 through 50 on the exam?
Yeah, that'd be helpful, I'm sure.
That'd be good? Yeah.
They're not denying it. They're like, we'll get.
Okay, let's play Kahoot.
Okay, so now I've got to just switch from. I gotta get
We're going to send from Twin Cities.
Yeah. Mike, can
There you go.
Can we switch?
We need. Well, we're not seeing your screen yet.
No, I know mine's up, but I gotta see if somebody else.
Okay, we got it.
You have it?
Can we have it on both? Well, okay, they can see it then. And we expect all players today, don't we?
All right, people. Flashback from. Stay focused, Twin Cities. Who is logging in as me? You better do well. Someone's got to log in as Dr. Beacham. I see it. Floppy baby. Ooh, I like the done one. Jason's not here. So many questions. I need more coffee. I like that one. I'm in agreement. I gotta figure out tap and go.
Aria?
I'd like to get a few more. I had 44, but then one person logged out. All right. Alyssa's just saying her name. Who is Miss Awesome? Who's gonna claim it? All right. Looks like we've got as many as we're gonna get. We ready? Where is Hodgkin's lymphoma least likely to metastasize? Okay. How many do we have? Go ahead. I can
And
see.
there is silence.
Any thoughts on why? Can anybody tell me why? Ask why? Say it louder. Not long enough, probably. Yeah. The thought was maybe blood doesn't really stay in the heart, right? Long enough. It's moving so quickly through it. Any other thoughts?
You never hear of heart cancer.
That's right. Ever heard of heart cancer?
Plus it wasn't in our cardiac section.
And
What did Corey say?
It wasn't in the cardiac lecture.
Okay, let's move on. Alyssa. Somebody logged in as Alyssa, just so you know. So we just, who logged in? Not Natalie. Who knows? Okay. Okay. What is a common first sign of osteogenic sarcoma? Very good. I actually thought my daughter had this when she had her meniscal tear. She had a synovial cyst that came out the side of both of her knees, and I was so worried. It was so hard. It was viscous. Anyway, but yes, limping is one of the key things here. Some of you said weight loss. I would say if you were thinking about a first sign and a best answer here, you'd probably go limping first and then possibly see weight loss, right? So a first sign might be your indication here of what's a best answer. Any other thoughts, Dr. Beacham?
No, that would be with a bone sarcoma. It would be limping.
Mm-hmm.
Yeah.
All right. So many. Which is not a cause of pediatric anemia. Wow. Job. Impressive.
Nice. Thank you.
You're caring for a 12-year-old with sickle cell anemia. What is a priority assessment? Oh, good, good. Okay. So many questions. Who is that? Who's going to declare themselves? Anybody? Rochester? Okay. Which hematologic disease process is a 15-year-old female vegan at risk for? Kind of an odd question. STEM. Good. Those of you who said osteoporosis, just think about all the iron stores that are missing possibly. So, all right. Any questions on that one? This same 15-year-old female vegan has iron deficiency anemia. What food? Hey, you guys are doing great. Huh? Oh, no, you got it wrong. I'm like thinking 35. Okay.
I said sorry. I led them astray with dark leafy vegetable greens.
Yeah.
He's probably eating them.
This might be cued in wrong.
It's a trick question.
Yeah.
What's that?
It might be keyed in wrong as the correct answer. We should check that.
Yeah.
Yeah, I don't think that's right. I think you guys are right with the 35 of you at the dark leafy. Those of you who chose beans, what were you thinking? Anybody want to share? Okay. Beans, there's the magical fruit. Right? Beans. Mm-hmm. All right, the parent tells you that their 4-year-old is having frequent nosebleeds. Rule out what?
You should know this because I told you not to study it.
Are you answering these? Are you? What's your name? Good. Although we have a split on anemia and, well, kind of all 3 of the others. But yes, got to think of bleeding, a bleeding disorder. Just, it's where we all go. What did you say as a trick question? Why do you think that?
No, I said I just feel like it was confusing, like wording.
Oh, it's totally confusing. You only have so many characters. So, and the TAs last semester put some of these together, and yeah, it is. All right. The last one of this one. A newborn getting a circumcision does not feel pain. One said, one's joking. They do feel pain. Who's so many questions? Who won? Should have had treats. Is that you? Ryan's trying to claim it.
You're here.
Sarah is? Sarah's?
Dinner
Oh, did
here
I
in
see you?
Rochester.
Good job. Who's Floppy Baby? Yeah, right. Got the Twin Cities. All right, who's KT?
KT.
Oh, that's you. She's like, that is me. I like it. All right, let's do it again. We got to log back in, I believe, on this one. Yeah, you do. We're still going to get out early. While you guys are signing in, just remember that the Jula course, the elective course, has space still. So if you want to register for that, please go ahead and do it. Okay? 2 credits. I sent out a course announcement about it. Look at that. Lovely. Claim it. Nick signed in as himself. No. That is. Now we got people actually claiming it. Soon to be seniors. How does that feel? Everybody? Yeah? Woo-hoo! 46 last time. There we go. Let's do it. Which of the following is not a function of the endocrine system? Really good. Okay, metabolism, that would be one of the number one things that is affected by the endocrine system, okay? Enable sexual reproduction. Those, when the endocrine system's off, it wouldn't be directly correlated, but it does support the pituitary and the hypothalamus as well. So all that's intertwined, and so that would affect those kinds of things. When you think of adrenal stress, you're going to have all of that affected with the sexual sort of hormones and things like that.
Well, and your testosterone and estrogen are hormones.
Yeah, so I said, yeah. The sex hormones, yeah. Okay. All right, got names up there now. What part of the body is the main regulator for hormone regulation? Pituitary. When you think of the different axes, so you do need to know that. The adrenal cortex does support that, though. Okay. Rank the time of onset from shortest to longest. Some of the students here don't know that I can hear them, actually. Hard question, Steph. I'm talking about influence. This is a tough question. You're getting a lot of time. Just a slight confusion with the regular and Humalog, MPH and Lantus, okay? So that one should actually be, that's funny. That one looks the same as, regular then Humalog. No, that's right. Okay. I was going to say that wasn't right. Okay. I'll leave that one up there for you. It's a good one to know. Okay. Nah. Who's that? Can I leave? Don't hurt our feelings. It's sad. Mr. Corey. A patient with Graves' disease may have what symptoms? Get a lot of time on this one. Okay. Looking at these. So the key here is the increased heart rate, for sure. Anytime you see that, that's going to be an indicator. And I believe there's actually quite a good chart in your PowerPoints on this, where, you know, some of that was added, like oh my gosh, I'm drawing, Jana Gerwitz O'Brien, I believe. Is that correct? Is that who came for this? Or did Dr. Beacham, did you do this one, or did Jana?
I did.
You did this one.
And I don't believe I talked about Graves' disease.
Okay. That in her slides, or? Hyperthyroid, did we do any of that?
Yeah, but I don't think I called it out as Graves' disease.
Okay. Hypo, yeah.
Yeah. Yeah, we had the good slide on hypo, the difference between hyper and hypo. But yeah,
You know, as we're looking at it, the green one does have the intolerance, I believe, because heat's in both. IBP, increased heart rate, weight loss, yep, accelerated growth. Hair loss. Yeah, I believe green as well. So take a look at those and just copy that down as a patient with Graves' disease. Everybody good? Okay.
so it does look like, based on that chart from the book, that green, the square answer, that last answer was also correct.
Yeah, that's what we're saying too. Malin confirmed that for us. All right, hyperglycemia is a blood glucose above or below 100. Many of you put 120. Can you explain why? Just make sure we're got the right in there. It does. Usually it's a cutoff too for, so confirming that this is not the right. Dr. Beacham, can you also check on this one? Because that's what I always knew is 120.
I remember
On our chart, it
about
says
this
about
because then with your diabetic ketoacidosis, it's above the 300 range,
Mm-hmm.
and then including the acidosis, and then there's a PowerPoint that says it's above 160.
Yeah, but when we diagnose hyperglycemia,
There's this chart, and I have it in my notes, and like on the top it says like hypo less than 60, hyper greater than 160.
yeah, I was more thinking when I looked at this, it's more around when we look at when it's in that above range, you know, of the 120. But we're hearing that there is a chart, and the book confirms it too, that it is above 160 or above, I should say. Okay. Is which of the following is a priority for an unconscious person with hypoglycemia? They're unconscious. Good. The only reason why we wouldn't give the 15 grams PO, right? If they're conscious and we can get something down, then that would be much easier. Knowing some kids that have this, they know exactly what to do. But because they're unconscious, they can't get that. Minor detail. All right. Okay. following a repair, a VSD has a high mortality rate. True or false? You don't know? Good. That is false. They have a really good mortality rate. Okay? Which of the following is not part of the tautology of flow? Oh, we've got people like excited here. Why did people think of PDA? What is a PDA? Anybody remember?
Patent ductus arteriosus.
Yes, patent ductus. Why is that important? What is that? Does anybody remember? That's the way that we connect, right? Fetal circulation and yeah. Mullen says
In the PowerPoint, it says that right ventricular hypertrophy is part of it, and it can say
Yeah. Yeah.
Who got this right? Did you guys get that right? Where are your notes? Do you have notes or did you guess?
Oh, I guess.
It also has
Dr. Summernes?
Yes.
I think the gold circle is incorrect, which is not part of TET. Tautology of flow is ventricular septal defect, pulmonary valve stenosis, overriding aorta, and thickened right ventricular wall. So it should be PDA.
Let me see. Google says it too. Okay. Well, again, you know, we absorbed these. We will change that though. Got to figure out how to do that. I wonder if because of the way the stem's written, it just kind of read funny. That when they originally put it in, not a following or which is which of the following is. I don't know. We'll go on though. We'll fix that. We can just keep a note on that one. All right. IV prostaglandins are used for what during pre-op for transposition of the great arteries? You guys should all get this one right. We've talked about it. Good. Yep. Keeps it open. The PDA, that patent ductus arteriosus, so we can still get that circulation that we need. Okay, until we can fix that transposition. Okay. Avoiding strenuous exercise is specifically recommended with which cardiac abnormality? Good. Excellent. get to the last one. What position is used to treat a TET spell? Yes. Okay, knee chest. Good. All right, so the one that said, can I go yet or can I leave? You can. All right. It's been fun having you guys. You guys have to keep stopping by. We're going to lunch with a few of you who wanted to take us out, so anytime you want to do something like that or connect with us or come do office hours or whatever. Okay, we'll see you though for ATI and for the final. Okay,
Yes.
Remember, it's just 1 hour you get for it. We schedule 2, so we have our room for long enough in case there's any issues. Any other thoughts, Dr. Beacham?
Nope, I don't think so. It's been a pleasure. You guys have been really attentive and interactive all semester, and I certainly appreciate that. The other thing I do want to mention is that I will be posting a invite to anyone and everyone that would like to help out with some research this summer at the State Fair. Alessandra participated last year, so she can give you any of the specifics. But it's a great time. I'm still waiting for the shifts, but if you're interested, send me an email and I'll put you on the list. And when we get the dates, I'll send out more information about it. Okay, have a great rest of the semester and hop by anytime.
Sorry, guys.
Do I go to see you?